Let me introduce Dr. Uday Phadke. He's a senior endocrinologist and a fellow of the American College of Endocrinology. And he's going to teach us a little bit about what we need to know and only what we need to know about diabetes.
All
Uday,
right.
thank you for accepting our request.
Pleasure, Dr. Sudhir, and thank you for inviting me to your forum. It's a pleasure talking to you all. And what I'm going to do in the next, the time allotted to me is to take you through some basic insights into how we treat diabetes in the present scenario. Now, if this question was asked maybe a few years ago, actually when I was doing my MD or my initial part of my DM endocrinology, the answer would be very simple. There are only two oral drugs. You either use a sulfonylurea like glibenclamide or you use metformin. And of course, we have moved quite a bit ahead from there. One of the most important recognitions that has actually come in is that diabetes is no more a single disorder. It is basically, especially type 2 diabetes, is a syndrome, and hyperglycemia is just one part of it. So when you say I am treating diabetes, and when you say the sugars need to be controlled, you are actually treating just a portion of that particular syndrome. And because it's a syndrome, there is no single unifying pathogenesis. There are multiple pathogenic mechanisms, as I'll show you. It is extremely common in our country, and it's believed that almost 16% of the adult population living in the urban areas and about 7 to 8% of people living in rural or semi-rural areas suffer from type 2 diabetes. And since it's not curable, we need to take care of it lifelong. And the whole idea is that you cannot casually or randomly choose drugs as per our own personal whims and fancies. We need to choose wisely because we need to take care of the patient long term. And as I said earlier, you have to consider many problems, hyperglycemia just being one of them. So the other problems that you need to look at particularly is that over the lifespan of a patient, obviously there are so many things that are going to come up. So the patient could become pregnant, the patient could be infected, he or she could have a trauma, there could be development of cardiac, hepatic, or kidney disease. Aging, which is natural, is bound to come to each and every patient, and we need to formulate a strategy of how we are going to change a treatment as per age based on retinopathy, whether there has been a stroke in the past, neuropathy, and so many others. And all these things are taken into consideration when we actually choose drugs. Now, the problem really is that if you look at 16% of the adult population, the number runs in millions, and there are just simply not enough specialists to take care of this. And therefore, treatment has to be started by the doctor who sees the patient first. It need not necessarily always be a very specialized treatment, particularly for non-complicated cases, but at least we should address certain aspects of it, at least advise on lifestyle, at least start some basic drugs, and then if need be, refer these patients to specialists for some additional therapy based on the current scenarios. Now, if you look at the diabetes pathophysiology, which was taught to us in maybe MD, when we are doing our MDs, it was basically a triumvirate. There was excess glucose production from the liver. There was decrease in insulin secretion from the pancreas, that is the beta cell, and the peripheries, typically the muscles, would not utilize glucose. And you had two kinds of drugs for that. One was metformin to reduce liver production, sulfonylureas to produce more insulin, and to decrease peripheral or to increase peripheral glucose utilization, we had exercise. So treatment was basically that simplified because we did not know more mechanisms. Of course, as things have moved ahead, from the triumvirate, we moved to the pentad, and from the pentad, we have now gone on to what is called the ominous octate. And from the ominous octate, we have now moved on to a dirty dozen, to all kinds of new acronyms and names and monikers that are being given to different pathogenetic mechanisms that are being discovered. And I'm just going to show you a few here to tell you that apart from the first three that we had, we also now have problems where fat cells are implicated. So in the upper right hand corner, you will see that if there is excessive lipolysis, there is increased free fatty acids in the circulation. They cause insulin resistance. Then, of course, apart from the alpha cell, from the beta cells that we had, you will see right on the opposite side at the 9 o'clock position, you will see that the alpha cells are also now implicated. They act by increasing the glucagon secretion, and glucagon, as you know, is a potent anti-insulin hormone, and therefore it negates all the insulin actions. And what is also interesting is the brain is also involved, and there is supposed to be a neurotransmitter dysfunction, and certain drugs have been tried for that. The decreased incretin effect, about which I will speak later, and this incretin effect is something which is very interesting because it not only acts or not only modulates the alpha and the beta cells of the pancreas, but it also acts on the brain to stimulate satiety. It also acts on gastric emptying. So this is something which is again important because it's now known that the rate of emptying of the stomach also will determine how much postprandial rise will occur. And at the 3 o'clock position, I've reserved that slot for an entirely new set of medicines or a new class of drugs called the SGLT2 inhibitors. These originated from a very funny kind of a mechanism in which the kidney, which was initially thought to be the victim of diabetes in developing CKD, is now known to be a perpetrator also of diabetes. And of course, we will see this later. And the importance of getting to know all these different mechanisms is that if there is a new mechanism, there is obviously going to be a new intervention, and more the merrier. And therefore, we have more, let's say, arms in our armamentarium to tackle this huge problem. Of course, today's lecture is meant to introduce all these basic armaments that you have at your disposal. One thing which is very important is, and which is probably missed by generalists, is to realize that target organs can be damaged even before diagnosis of diabetes. And if you see this graphical representation here, even before overt diabetes, by overt diabetes, I mean hyperglycemia occurs, you will see that macrovascular complications, that means typically CAD, CVD, could begin almost a decade earlier. That means the seed of the macrovascular complications is already there. You can see also on the graph that as the duration of diabetes increases, typically the microvascular complications will start coming in. That means nephropathy, retinopathy, and these are believed to be as a direct result of hyperglycemia. Whereas the macrovascular complications are predating and they originate from a common soil which causes both macrovascular complications and diabetes, insulin resistance being one of them, obesity being one of them, racial characteristics being one of them. You will also see in this graph something called beta cell function, and you'll see denoted by the dark blue line that it's a progressively and an inexorably downward curve. So no matter practically what you do, with every passing year of diabetes, the beta cell function is going to go down, and ultimately insulin production will be almost at a near zero. These things have to be kept in mind when we begin therapy for diabetes. So what should our aims of therapy be? Naturally, since hyperglycemia is one of the chief uh, signs, or shall I say, a chief presenting mechanism of diabetes, we must control sugars. And by controlling sugars, what we predominantly achieve is actually control of microvascular complications like retinopathy, nephropathy, and cataract, and also prevent infections. So this is what we really do. In younger patients without comorbidity, this may be our only concern. That means control of glycemia. However, in people who have associated comorbidities like cardiovascular disease and CKD, just the control of sugar is not going to be enough. We will have to use certain sets of medicines, apart of course from antihypertensives and statins and antiplatelet therapies, drugs which are also going to modify the course of cardiovascular disease and CKD. So this something is very important to remember. Otherwise, if we just control sugars and satisfy ourselves that the sugars are decent, yes, you will be able to prevent some degree of nephropathy, retinopathy, neuropathy, but it may not necessarily target the macrovascular complications. Now, when is a specialist reference really speaking required? So I would say that as soon as diagnosed, if the patient has complexities, so if you're seeing this patient, say with a stroke or a myocardial infarction, already has some borderline creatinine, has albuminuria, yes, this patient definitely needs to see a specialist after you starting some basic therapy. If there is no complexity, then by the age-old teaching, you could put this patient on metformin and any other drug that you are comfortable with, that you have used in the past, if this patient is non-complicated. If he is well controlled and is doing well, no problem. If he is not, certainly needs to see the diabetologist. Having said that, my thinking is also that once at least after the diagnosis of diabetes, the patient needs to see a specialist. And I'll tell you why I say so. He may not necessarily continue seeing him, say, regularly every week or every month. That's not really necessary. But typically what happens is that unless he sees a specialist, the diabetes diagnosis is kind of trivialized. So if the sugars are just borderline, many people will tell him that, look, it's no bother, it's just borderline, you just take care little care of your diet and exercise, you should not worry about it. The patient believes it because he has no symptoms. But if a specialist talks to him, tells him what the future might hold for him, say after 8 years, 10 years, what are the different targets that are recommended, how we are going to progress in therapy, I think at least one session with a competent dietitian and a diabetologist, I think would make him cognizant of his disease. And then of course he could continue following up with a generalist. The first 5 years are most important. And this has come out repeatedly from multiple studies. And we call this the legacy effect, which means that a person who is well controlled in the first 5 years, even though his control may slip in the subsequent years, opposed to a patient who is always uncontrolled right from the beginning, you will see a dramatic difference in survival and complications at the end of, say, a decade or 2 decades. And that is what is going to matter. And this is typically the first 5 years are most often neglected when the person has not been cognizant or has not been made aware of what he needs to do, really speaking. How are we going to deal with this person? What are the drugs that are in our armamentarium? And first, of course, we will look at the oral drugs. The importance is, the principle of all drugs is that there has to be some endogenous insulin inside the body, because no matter what you do, unless there is some amount of insulin in the body, no drug will act, including metformin. So if the pancreas has completely failed, there is no choice but to start insulin. But if it has not, then you can try certain drugs based on the characteristics of the patient. Also remember that diabetes is a progressive disorder. It's not like hypothyroidism where you put the patient on thyroxine and 98% of patients will remain well controlled on a specific dose for all their lifespan. In diabetes, every passing year, you will need different therapies, more accelerated treatments. We need to remember that every drug has a shelf life, what we call durability, because ultimately it produces more insulin inside the pancreas. And the ability of the beta cells to produce insulin, since it is limited, that drug is going to fail. The lowering of HbA1c, any drug that you take, the maximum lowering, generally speaking, is about 1 to 1.5%. So obviously, if you're dealing with a very high HbA1c, naturally, you're going to require multiple drugs. So if you start with a HbA1c of 13 and expect that only 500 milligrams of metformin is going to control this patient, no, it's not going to happen. We might need polytherapy. Now, how do we decide therapy? And of course, how do you all also decide therapy to at least begin with? So first and foremost, we need to decide we need to know what the HbA1c is. As I said, if the HbA1c is borderline, the diabetes duration is quite recent, we need not target this patient very, very aggressively. What we could do is try lifestyle modification, we could try diet, we could try just one agent, see what happens. If he's not controlled, maybe add another agent and so on. However, if the HbA1c is higher, if the duration of disease is higher, typically we will need more medicines. So we could use 2 drugs also to start with. There is no such that we must start only with diet, only with single drug, only with 2 drugs. No, you will have to take a call. And this actually comes a little bit with practice and also by looking at factors which are going to decide therapy. The age matters. More elderly the patient, the less aggressive you should be. Because if you aggressively control this patient and he lapses into severe hypos, the chances that he will get a stroke or a myocardial infarction because of the hypoglycemia are high. Plus with age, there is some reduction in kidney function. We need to be careful with elderly patients. Go slow, start low and go slow. And typically, as I said earlier also, if there are comorbidities, the prescription is going to be different. And here I think the best way is that these patients see a good specialist. Now, what do we start with? Lifestyle modification. Does it work? Oh, yes, it does. And initially, what was believed was that by doing following a correct lifestyle, we could reduce not more than 0.51% of HbA1c. Beyond that, we still needed drugs. And this particular concept has now been trashed. And we see patients even coming with HbA1c of 10% if they are following a correct and a genuinely rigorous lifestyle, which is persistent and consistent, we can get them down to 6.5 also. How long it will last is anyone's guess. But to begin with, yes, lifestyle positively works. And the role of lifestyle is especially important in the early part. That means just after diabetes has been diagnosed. If you start telling the patient to do some kind of strict diet 10 years after his diabetes, yes, it will work partly, but if it's not going to make too much of a difference. Keto diets, intermittent starvation diets are all coming into the picture. They all have their place, and maybe we could discuss it during Q&A if someone is interested. But yes, they do have some place in therapy. And once these lifestyle measures fail and you have still not met your goal, this is an important thing. You need to set a goal for your patients. So for young patients, I would set a goal of at least 7%, but I would try and go down to 6.5%. For very long-standing diabetics, Elderly patients, those with comorbidities, I might relax the goal and even keep it 8%. Not a problem. So as I said, metformin has often been the gold standard up to now if you have to begin therapy. Although this is not based on one specific data point, it has just come out of habit. And this started off from an old study called the United Kingdom Prospective Study, where it was shown that the data is only of about 500 patients. And it said that if you use metformin in obese patients, it is helpful to reduce cardiovascular disease. After that, metformin never has been put to test like other drugs. But yes, it's cheap, it is effective, it does reduce weight, it is simple to use, generally no major complications, no hypos, safe for heart disease. So you could start. As a neurologist, you are absolutely justified if you need therapy to start with metformin. However, if there is a significant coronary artery disease or CKD which is underlying, metformin need not be the starting therapy. So this metformin has to be on board every time has been given up. You could start from different drugs also. As I said, this concept of using two drugs right from the beginning has been tested now in a recent trial. And this is very interesting. This is called the Verify trial. I'm not going to the details of this trial, but what they did was they compared metformin alone versus metformin plus vildagliptin right from diagnosis of diabetes. And what it showed was that the durability of control, that means the chances of this patient failing and requiring another drug, was clearly less when you started two drugs right from the beginning. So this is a new concept. It's not completely accepted and has come as a guideline as yet. But yes, certainly people say that given people's proclivity of not actually using, of not usually following lifestyle rigorously, one might be justified in starting a dual drug and leave him alone. We know that he will at least be well controlled, even if he does not follow lifestyle. And insulin is starting therapy in certain groups of patients with a very uncontrolled, losing weight, catabolic, etc. There used to be a definition based on HbA1c levels. That means if HbA1c is less than 7, just use lifestyle. If it is between 7 to 8, one drug, 8 to 9, two drugs, more than 9, three drugs, or add insulin. But this dogma has been given up because, as I said earlier, even people with HbA1c of 10 can come down to 6.5 provided they are just recently diagnosed and they are following a very rigorous lifestyle. The basic principles of drug therapy, whatever drug you use, that drug has to be effective. So, suppose you're dealing with a HbA1c of 9 and your target is 7, you must know that this drug should be powerful enough to cause a HbA1c reduction of 7. And the drugs typically which have that are sulfonylureas, metformin, gliptins, and insulin amongst the older ones. And now, of course, there are new ones which can bring it down further also. So if you use alpha glucosidase inhibitors, like say voglibose or acarbose, they're relatively weaker. They will not be useful in that situation when the sugars are high. They shouldn't cause hypos frequently because hypoglycemia is now a surrogate marker for more mortality, especially in elderly patients. Shouldn't cause too much of weight gain. In fact, should in fact achieve some weight loss. It should be safe for heart and kidney. And in patients who already have CAD or CKD, the drug should not only be safe, but it should further reduce the chance of cardiovascular events. Now let's take a few drugs one by one. What about metformin? Metformin basically acts on the liver and to a certain degree reduces peripheral glucose uptake. So metformin is extremely useful when the fasting sugars are high because the fasting sugar is typically dependent on liver output. The HbA1c reduction is about 1 to 1.5%. Yes, it does cause some amount of weight loss and some reduction in appetite. Hypoglycemia is very rare because it does not cause insulin production. And of course, it is good for lipids. It tends to reduce triglycerides a little. And in obese persons, there may be some CV benefit. As I said, this data comes from the UK PDS study. There are some contraindications to metformin. You would not use it in a very elderly person, a very debilitated person, and in people who are sick. That means advanced CKD, poor LV function, advanced decompensated liver disease, or hemodynamic instability. You would certainly not use metformin for sure. So often, as I said, up to now, metformin has been generally the choice for reasons which I mentioned, except, as I told you, if there is established significant CAD or CKD, I don't have to use metformin. I could use metformin if required for control, but I would use some other agents which I will come to later. These are the other conditions which I've already told you. Poor appetite, nausea, convalescence from major illness or surgery, admitted patients, metformin is not a very good drug to use. What about the sulfonylureas? Sulfonylureas after metformin are one of the most popular medicines, especially in India. There are several reasons for that. That they're very effective and they reduce the HbA1c by about 1 to 2%. Not only that, they're very cheap. And the combination of metformin and sulfonylureas that are available in the market are literally like 2 or 3 rupees. So when a generalist prescribes it, he often tends to use these drugs because they're cheap. The patient is not worried that he's spending too much and the sugars do come down. The problem really with sulfonylureas is that they cause hypoglycemia and they cause weight gain. That's important. They do remain durable for about a couple of years and then they start losing their effect. But the main problem is severe hypos and weight gain. And this hypoglycemia is particularly very important when used in elderly people, as I said, or in people with CKD. The problem is they don't cause cardiovascular disease, but they don't have any advantage in people with cardiovascular disease as well. So they don't modify the process of progression of cardiovascular disease or CKD. So they are good drugs to use for glycemic control in people who do not have any complications, but they kind of lose their charm when you're using it in complicated patients. So that's about sulfonylureas. The modern day sulfonylureas, I'm sorry I missed this slide, but they are glipizide, which is available as Glinase common, glibenclamide, which is Deonil. We don't use this drug very often now because it's very long acting. Glimepiride is a very commonly used drug and there are many brands, and gliclazide, which is also a very excellent sulfonylurea to use in many patients. The next group of drugs is called alpha glucosidase inhibitors. Now, what do these alpha glucosidase inhibitors do? And the typical drugs are acarbose and voglibose. Miglitol is slightly older, but voglibose is very common. And what they do really is that they inhibit the enzyme called alpha glucosidase, which breaks up the complicated starches, the starchy foods, into monosugars. So what they do is they delay the absorption of carbohydrates. They don't prevent it. So what they do is flatten the curve, and flatten the curve is a very relevant concept, especially in modern times. So that's what they particularly do. They flatten out the curve. So the rate of rise of sugar after meals is flattened out, and therefore you do not get a large spike in the postprandial sugar. The important point is that they should be taken with the first bite of each meal, because they have to be in the GI system when the food is there, and only then will they work. If you take it, say, half an hour before or after the food, it's not going to work. So it doesn't have any hypoglycemic side effects because it does not cause release of insulin. It does not have any cardiac issues. It does not cause increase in weight. But yes, because it slows down the carbohydrate absorption, it does allow more carbs to reach the distal intestine and therefore allow it to get converted into methane, and therefore this gaseous bloated feeling which some people cannot live with. But they're good drugs to use, especially along with metformin, typically when you are dealing with mild postprandial elevations. But they're not very strong drugs. They're relatively weak drugs, and they will at the most reduce your HbA1c by about 0.5 to 0.8%, not more. They're not very powerful drugs. The next group are called the thiazolidinediones or glitazones, and you may have heard of pioglitazone or rosiglitazone. Now, this is an extremely interesting molecule. This is a true insulin sensitizer. That means what it does really is that it increases the effectivity of the insulin that is produced inside the body. And a lot of research was done when these drugs came into the market, and significant number of effects were actually found to be beneficial. Number one is, what they do is they take away the peripheral fat and put it into the lipid cells, that is the adipose cells. Therefore, they reduce the amount of circulating free fatty acids. By doing that, they typically reduce the insulin resistance. But what happens is that because they are taking away the circulating free fatty acids and putting them into stable adipose cells, typically you will find that the weight increases. They also act on muscles and increase the action of insulin there. Therefore, the peripheral glucose uptake is markedly enhanced. They also act on the liver. They take away the ectopic adipose tissue, which is deposited in the liver in the form of when we see the fatty livers, and put it back into stable adipose cells, thereby again reducing steatosis. They are supposed to reduce inflammatory markers, and they are supposed to reduce cardiovascular disease. So the drug class came with very significant promise, but ran into trouble when Steve Nissen published a meta-analysis in which he said that rosiglitazone not only is not doing anything to the heart, in fact, it is causing more myocardial infarctions. There's a big uproar. GSK lost the rosiglitazone molecule heavily. Pioglitazone was still considered to be safe, but again, the use of these glitazones has gone down. Interestingly, the ADA, which had a black box warning on rosiglitazone for all these years, has now released it back saying that it does not really have any increased risk of myocardial infarction, but it's now dead and gone. Nobody will use rosiglitazone anymore. So just see how a single study by a prominent figure in medicine can just destroy a drug which was a blockbuster at that point of time. The problems with pioglitazone, again, as I said, are weight gain, significant fluid water retention, edema. It can precipitate left ventricular failure in susceptible persons, and it can increase fracture risk in menopausal women. And the problem is that where does it act the best? It acts the best in people who are severely insulin resistant, which means they are already obese, they are centrally obese, and there, because it is working, they will have the maximum side effects because they are now insulin sensitized. So they will gain more weight, they will have more edema. So it's like a catch-22. It will work beautifully to reduce sugars, but also cause the maximum side effects. We now come to a very interesting class of drugs called incretins. And what is this incretin thing? The incretin effect was basically described when people realize that when you eat sugar, you will get a certain rise in insulin level. If you take IV glucose, you will get a certain rise in insulin level and of course glucose levels. And what they found was that if you ate something, the insulin rise was much higher and the sugar was much lower as compared to the same amount of sugar given intravenously. So they concluded that there is something inside the gut which actually, when it senses food, it stimulates insulin release. And because it had that incremental action on insulin release, they called it incretin, incremental. And these drugs are now called the incretin groups of drugs. There is a oral drug called DPP-4 inhibitor. I'll come to that in a moment. But what do? They increase insulin, but simultaneously, this is the first drug which also acts on the alpha cell. No other drug acts on the alpha cell. It also causes reduction in gastric emptying. As I told you earlier, if the stomach empties slowly, less comes into the intestines, and therefore the absorption slows down. The peak is flattened. And of course, by a central effect on the ventromedial hypothalamus, it reduces appetite. Now, inside the body, these GLP-1s, as they are called, the glucagon-like peptides or incretin hormones, are rapidly destroyed by an enzyme called the DPP-4 enzyme. Now, what we have is a strange drug, which is this DPP-4 enzyme, which is our enemy right now because it is destroying an important hormone. So an enemy of that, which is the DPP-4 inhibitor, is our friend now. So gliptins are the drugs which block the DPP-4 enzyme, and they increase the action of GLP hormones, thereby causing all these effects of increased insulin, decreased glucagon, decrease gastric emptying, and decrease appetite. So the typical drugs that you might have heard of are sitagliptin or Januvia, vildagliptin or Galvus, linagliptin or Tradjenta. So all of them are efficacious, they're durable, they don't produce hypoglycemias because the insulin production, as opposed to sulfonylureas, is dependent on ambient blood sugar. So if the blood sugar is 100, they will produce some insulin. If the blood sugar ambient is 190, they will produce more insulin. So it's not that like that with sulfonylureas. Even if you give a tablet of Dianyl to a person whose sugar is 80, it will take it down to 30. That's not the case with gliptins. They're therefore pretty prescribe and forget drugs. They don't have too many side effects. And we now have a cheaper drug, which has come to us from Japan. It is called teneligliptin. By and large, as efficacious as all the other, I would say, Western molecules. But there is that small lingering fear that it could cause elevated QTC intervals and thereby cause ventricular arrhythmias. And apart from this, we have an even more powerful agent, which is an injectable drug called dulaglutide. You might have heard the name of Trulicity or Aplivant. This is an injectable drug. It can be given once a week. The point really is that it not only lowers sugar and reduces weight, but this is one of the first drugs approved by the FDA, US FDA, both for primary as well as secondary CAD prevention. It's a huge jump for this class of drugs. So any person who has a high risk of developing CAD can be started on this drug because the chances of him getting an event are significantly lesser. But of course, it's expensive. It's an injectable drug. And now we come to a totally new therapy, and this would be the last drug class that I would be discussing. Up to now, we were discussing drugs which targeted the pancreas, liver, the muscles, fatty tissue, glitazones, sulfonylureas, gliptins, metformin. And then came the discovery that, as I said earlier, kidneys are not only the victims, but they are also the perpetrators in diabetes. And what they do is that in the face of hyperglycemia, the kidneys are supposed to actually not reabsorb so much of glucose. But what they do is that this enzyme called SGLT2, sodium glucose cotransporter 2, starts actively reabsorbing more and more sugar from the kidney, from which it is filtered. And therefore, instead of helping the body, it is actually worsening the problem by adding more sugar to the drugs, which are called the SGLT2 inhibitors. We prevent this reabsorption to almost 90% and thereby cause glucosuria. And therefore, this lovely term is that if you can't beat them, at least join them. So this produces a massive glucosuria. And by producing this glucosuria, it not only causes weight loss, but it also causes significant reduction in glucose, not only glucose, but it also throws out sodium, water, and uric acid. So other damaging uh, materials that are seen in diabetes. Sodium causes worsening of hypertension. Uric acid, as you know, is a surrogate of the entire metabolic syndrome. These two are also helped by the SGLT2 inhibitors, and they not only cause glucoseuria and reduction in glucose, but what they also do is that they have significant number of hemodynamic effects. So they reduce systolic blood pressure, they change arterial stiffness, they have direct receptors on the left ventricular myocardium, they reduce actually what is called the left ventricle myocardial index, and a host of other features. They also act on the liver, they reduce steatosis. A number of features have been attributed to the SGLT2 inhibitors. I'm just showing this slide to this blue one is Sudhir's suggestion is to, can we delete this slide? But I decided to keep it because it shows you that in this EMPEREX study, there is such a marked divergence in the rates of death. And this is one of the first drugs in medicine which has actually reduced mortality in diabetics who have serious cardiovascular disease by a whopping 38%. It's huge. Not only cardiovascular death, but the same thing in heart failure as well. What's the catch in using the drug? Because they cause some equiresis and natriuresis. Postural hypotension, especially in elderly patients, other antihypertensive agents, those with critical cerebrovascular disease, we should be careful in using these drugs because they can precipitate a rather catastrophic first dose hypotension. Genital mycotic infections are very common because of the glycosuria. They sometimes may cause urinary tract infections, again because of the same mechanisms. And occasionally these drugs have been associated with peripheral limb amputations. Don't know why. Some say it is because of the hemoconcentration, because of loss of fluid, but the clear mechanism is not known. So if you want to summarize, if you're targeting therapy, you define at baseline what your target A1C is. As I said before, if no comorbidity, metformin could be your first choice. But if any comorbidity, then you need to look at other drugs. So for example, with CAD, CKD and LV dysfunction, you use either SGLT2 inhibitors or the GLP-1 receptor agonists like dulaglutide, the injectable one. If you're dealing with significant steatosis, pioglitazone is an important agent. If you're looking at a person who has past history of pancreatitis, please do not use gliptins because sometimes gliptins can cause pancreatitis. In elderly patients and those with CKD, use sulfonylureas if at all with very small doses because serious hypos can be a big problem. And in those with LV dysfunction and those elderly postmenopausal women, use thiazolidines with caution because of precipitation of left ventricular failure and fracture rates. And then of course we come to the quintessential questions that if ultimately one of the major factors in diabetes is insulin deficiency, why use oral drugs at all? Why not use insulin? And this was tested in the ORIGIN study. And I have not put the ORIGIN slides here, but let me tell you that at the end of 10 years, people found that for an equivalent control of blood sugars, either by oral drugs or by insulin, there was no difference in complications. So all other factors remaining the same, which means antihypertensive, statins, antiplaques therapy as when required. Just using insulin from day one did not make a difference in the complication rates. Insulin will definitely be required as diabetes starts advancing. And then insulin is of many types. I'm not going to go into that. Basal insulin, rapid acting insulin, combinations, a whole lot. And I think that is best left to specialists. So if I were to summarize what I said, so diabetes is a complex progressive disease. So there is not going to be a single golden approach. Multiple pathogenic mechanisms require multiple approaches. Drug efficacy is a more or less the same, but there is a lot of difference in how they act, where they act, when you should use what, and therefore you need to tailor to comorbidity. That is the most important point. There is no perfect drug because one drug is not going to solve all the issues. Each drug has its pros and its cons. Always use wisely and start early is my message. That is all that I had to say. Thank you again for patiently listening to me, and thank you, Dr. Sudhir, for inviting me to this lovely forum.
Thank you, Uday. That was an excellent talk. We'll now take a few questions. Can you stop the screen sharing?
Yes,
So
I will.
we'll see you. Um,
I've stopped it.
okay, so I'm going to ask you a few questions. It'll be like a rapid fire round.
Sure.
How many OHA can you combine with insulin and which of them?
So you can actually combine all of them except glitazones. Because if you combine pioglitazone or rosiglitazone with insulin, there is massive weight gain and edema. So you should never combine the two. Otherwise, all other drugs can be combined with insulin.
Okay, then somebody is asking how many OHAs can you try before you finally go to insulin?
Well, actually, you can try all of them, honestly. But, it's like this, that if you're already, let's say, on 3 drugs and your HbA1c is 10, it's most unlikely that addition of a 4th agent is going to cause some dramatic benefit. So you will need to be careful.
Maybe you diabetologists can learn from how we define refractory epilepsy. We've got a definition of what is refractory epilepsy and how long, because there's so many drugs you can keep trying. You don't do that.
Right.
That is,
Right. I absolutely agree with you. And actually in diabetes, although we say that, let's say the the maximum dose of metformin is say 2.5 grams, we believe that at about 1 or 1.5 grams, more or less you get the maximum effect. That's true for all drugs. The half maximum pharmacological dose will probably give you the maximum bio effect. So
okay.
there's no point in just increasing doses randomly.
Right. Okay, Dr. Dev D asked, what is the role of hydroxychloroquine in diabetes? Of course, there's none left in India. Mr. Trump has taken it all.
Well,
But
all the companies are actually ramping up their production because they see a very golden opportunity. Just raising that the market of hydroxychloroquine is about 15 crores something. They are now expecting that it will go to 150 crores just by exporting it to US and all across. So it's a big golden, they're laughing their way to the bank. But essentially hydroxychloroquine is a very novel thing. I'll not go into too much detail. The mechanisms are unclear still. Partly it is an anti-inflammatory effect, but the most important effect of hydroxychloroquine is believed to be that it reduces the degradation of insulin inside the cell by changing the pH inside the cell. The cytosolic pH is made alkaline, because of which insulin remains in the cell for a longer period of time.
so which patients would you use it in?
So we use it as the 3rd or the 4th drug. So the Drug Controller General of India has allowed it to be used as the 3rd or the 4th modality. And sometimes we get amazing results. It's dramatic. So some we don't. About 30% of patients will show some dramatic improvements.
200 milligrams or 400 daily? How much?
400 is the better dose for diabetes.
Okay. Okay. What about insulin? Do all patients who are admitted in hospital be on insulin only?
No, I don't think so. If they are well controlled, if they are not hemodynamically unstable, and they are on some kind of enteral feeding, whether it is a tube feeding or otherwise orally, they can remain on oral drugs. The main reasons for going on to insulin is severely infected patients, septic patients, multi-organ failures, we are not able to feed the patient, surgeries, body cavity exploration, etc.
Yeah, if feeding is not regular or you're not sure.
So that's one of the best
Dr.
indicators.
Tharkar wants to know what is your record? I mean, what is the highest HbA1c you have seen?
So I have seen HbA1cs of 18, 19 with people who said they were excellently controlled and coming for a bypass surgery. And they said that they have done their sugars yesterday and it was all well controlled. So it's all a hoax actually.
Okay.
but they had never checked their sugar. They had never bothered to take medicines. So 18 and all we have seen.
Okay. Okay. Then
Lazy,
Dr.
lazy figures.
Gajanan Panandikar asked, which is the oral drug of choice in a diabetic with CKD?
So it also depends on what stage of CKD we are seeing. If this patient has a GFR of between say 45 onwards, okay, say 45 to 60, which is about stage 3 CKD, then one of the best drugs to use is canagliflozin. That means one of the SGLT2 inhibitors. There's a very large trial called the Credence trial, which was recently published. So that has been shown to slow down the progression of CKD significantly. First drug to show so. Now the other answer to this question is if you can't use canagliflozin, then use drugs which are going to be least hypoglycemia forming for the patient. So gliptins are good drugs to use in renal failure. Gliclazide is good to use, but smaller doses. Metformin generally not if EGFR is less than 30. Insulin, of course, anytime.
Okay. These SGLT2 inhibitors, because of the diuresis, do they also act as antihypertensives?
Their antihypertensive action is not very strong. So they reduce in all trials. The reduction has been like the HOPE trial, about 5 by 2.5 millimeters of mercury.
Okay.
Systolic, diastolic.
Somebody is asking, how much do SGLT2 inhibitors bring down blood sugar in a patient with, say, HbA1c of 10? How effective are they?
So again, they're very effective. And we have seen that by just a single combination of SGLT2 inhibitor with, say, metformin, we have seen reductions of up to 4%. Of course, that's not the norm. The norm is again about 1 to 1.5 in all controlled trials. So if
But
you use...
you are saying one about with each. So is it one per drug? So
Yes,
metformin
one per drug, 1.5 per drug.
Okay.
But sometimes the effect can be 3% also with one drug or 4% also with one drug. That's something which is, very individual. And what I'm talking about is what has been seen with controlled trials. But in the real world experience, it can be more also. It is not limited to 1.5%. That's what I'm saying.
Okay, then there's a question of what is the chance of diabetes in a patient on saroglitazar?
So sorry, I lost you. I lost your
Have
audio.
you heard? Yes. So what is the chance of getting diabetes in a patient who's on saroglitazar?
No, so saroglitazar is similar to the glitazones.
Okay.
It's a alpha plus gamma thiazolidinedione, PPAR. So basically what it does is it has action similar to pioglitazone, but it has some additional action on triglycerides. So it has a fibrate-like action.
Okay.
So it's not a very strong anti-diabetic. So people on saroglitazar don't get diabetes. It can be a good drug to use if you have significant, say, triglyceride high with some amount of diabetes. There are trials on that. It's also being used now for steatosis. Some trials are available. The evidence is still not 100% strong.
Okay. Dr. Gajanan Panandikar again asks, in a morbid bedridden patient like advanced Parkinson or motor neuron disease with diabetes, which drug would be ideal?
So it all depends really on what your target HbA1c is and what is the current HbA1c. If his HbA1c is just mildly elevated, I would leave him alone with whatever drug he is currently on and accept a slight degree of, decontrol because of the long-term prognosis. But if his A1C is very high, then the same drugs that I showed you could be used in these patients, especially if there is a good caretaker with him who is likely to do the sugars at least intermittently. Because
Okay.
if he's not, then we will not certainly use sulfonylureas in high doses because we can't use them.
Okay. Dr. Hemant Joshi is asking, what is the role of glitazones in fatty liver disease and what is the maximum dose that can be given to avoid the chance of bladder cancer?
This bladder cancer thing is something I think which has been put aside now because there have been meta-analysis on bladder cancers. And I don't think we can really say that glitazones cause bladder cancer. I think that issue has been resolved.
Okay.
The maximum theoretical dose of pioglitazone is 45 milligrams. But by and large, again, we see good effects which are with 15 milligrams, and they're similar, almost similar to 30 milligrams, but the side effects are lower with 15. So I would typically in an Indian patient use 15 to 30, not more. 15 most of the times is what we use.
Okay.
And yes, they are used in NAFLD also.
Okay, we have two questions on insulin Lantus. One person is asking HbA1c 10 on insulin Lantus, 35 at night, diabetic for the last 10 years, what to do next? And so Dr. Majid is asking, what is the utility of Lantus in neurology practice? Insulin, I know we didn't cover, but in brief, would you?
Okay, so Lantus is what is what is Lantus? Lantus is a basal insulin. That means it provides a background insulin over 24 hours. So let's say if you are given 36 units of Lantus to this patient, let's say for calculation purpose, it will give about 1.5 units every hour to the patient. But there is no mechanism with Lantus that it will rise after the postprandial peak. Therefore, just giving Lantus, if your HbA1c is 10%, it obviously means that you're getting a lot of surges in the PP sugars, and it's time to move ahead with more number of insulins. So only Lantus is not going to be enough. And I'm not aware of any specific use of Lantus with neurology. I mean, if I'm missing something, he could elaborate, but I don't know of any.
Okay. Pioglitazone, according to IRIS, Dr. Pramod says that pioglitazone, according to the IRIS study, is the drug of choice for stroke prevention. Is it really problematic?
Actually, well, that's an excellent point. I think we missed it during the presentation, that amongst all the drugs that have been used for diabetes, whether it is metformin, insulin, SGLT2, GLP-1, they have all reduced CKD, they have all reduced myocardial infarctions, LV failures, cardiovascular events, but none have reduced stroke, and only pioglitazone has been the drug which has actually shown in the IRIS trial to reduce stroke incidence, although the effect is not massive. So yes, but there is a definite, and thank you for bringing up that point. It's very relevant.
Okay, somebody is asking a question. Luckily, that person is anonymous. He's saying, what are lifestyle measures?
Is that you?
No, I didn't.
Okay, so basically what lifestyle means is that following a pattern of life, which includes several things. It includes diet, it includes exercise, it includes sleep management, it includes vices management, and it includes mental strengthening capacities like meditation, all to achieve at least a goal which is tangible, and that is a weight which is closest to your target body weight, and achieving a central waist circumference of less than 90 at least for an Indian. So that is what lifestyle means.
Okay, the important thing is sleep is also important for diabetes.
100%. So there are lots of articles of sleep apnea correlating with diabetes, and not only sleep apnea, but just shift workers, those who work in BPOs, call centers, those who have an inverted sleep pattern have almost threefold increase in the incidence of diabetes at young ages. So it's very clear. And there is a very clear mechanistic explanation for that also.
Your favorite question, what is the role of intermittent fasting in diabetes?
Well, I wouldn't say it's my favorite. Well, there are different kinds of diet, and all of them have been tested. And actually, all kinds of diets are useful. Okay. If you are able to achieve a weight which is close to what you need, whatever you're following is going to be helpful. The intermittent starvation theory is based on several scientific facts also. uh, we still don't have the complete picture. But what it says is that if you're able to starve for a significant portion of the day, the whole hormonal milieu is changed in such a fashion that insulin resistance is reduced, insulin secretion is increased, and clearly there is a change towards better, not only for sugar, but also for lipids. Now, this theory hasn't really been translated or tested over a long period of time. There has been no long-term scientific control trial. Nobody knows exactly how much should be the duration of fasting. Some say 16 hours, some say 8 hours, some say 12 hours. There are some misconceptions also about intermittent fasting. So some people believe that you eat twice a day, but you eat as much as you want. That's never going to help. So you will still have to follow basic principles of carbohydrates, fats, etc. But if you reduce the number of meals, you always reduce number of snackings also. That is one important thing which quickly kind of gets these patients to
And
goal, because
once told me that if you reduce the feeding time, the total hours that you eat,
yes, yes,
automatically your caloric intake comes down.
absolutely. So it's very simple. So suppose you get up at 6:30 and you go to bed at 10:30. One of the simplest techniques is not to eat anything till 9:30 in the morning. So you take away 3 hours from morning, and not to eat anything after 7:30 in the evening. So you take out 3 hours from there. And even this is found to help. So as I said, there is no single prescription,
Right.
but for those people who have a tendency of snacking, for them intermittent fasting works probably one of the best.
Yeah, it has worked for me, so we'll continue.
All
Uh,
right.
I think there are lots of questions. So can you do one thing?
Yes,
I will email you some of the questions. I'll just create
certainly.
some questions, and maybe you can just uh, take a video of yourself answering the questions and send it to me. I'll put it up on the.
Wonderful.
We are going to put this talk on the YouTube, so we'll put up your questions also. I
All
think
right.
we've had a wonderful talk and very nice discussion. I'm sorry I could not take all the questions that are there, but we will try to answer them offline. Thank you, Uday, and have a great day.